Neurology quiz number 61. Discuss mechanism of action, uses, side effects and dosing of Lamotrigine or Lamictal. Lamotrigine is a broad-spectrum AED. It is FDA approved for focal seizures, generalized tonic-clonic seizures, and Lennox-Gastaut syndrome. It is also effective against generalized absence seizures, but efficacy is less than valproate and ethosuximide. It can be effective against myoclonic seizures, but may exacerbate them in some patients. It is FDA approved for bipolar I disorder. The drug blocks sodium channels. It also inhibits glutamate release. It may have other actions given its efficacy in absence seizures. Oral bioavailability is excellent, more than 95%. Tmax is 1 to 3 hours, half-life is 15 to 35 hours, and time to steady state is 3 to 7 days. Protein binding is 50% but not clinically significant. It undergoes extensive hepatic metabolism, predominantly by glucuronidation, and the inactive metabolites are excreted in the urine. 10% of an oral dose is excreted unchanged in the urine. It undergoes autoinduction so that clearance can increase by 20 to 35%, requiring dose increase when given as monotherapy. When administered with valproate, the half-life is prolonged to 30 to 90 hours. Felbamate also decreases its clearance. When given with enzyme inducers, half-life can be reduced to 8 to 20 hours. AEDs that lower its levels include carbamazepine, oxcarbazepine, phenytoin, phenobarbital, and primidone. Oral contraceptives in pregnancy can also increase its clearance and decrease levels. Lamotrigine does not affect metabolism of estrogen-containing contraceptives, but it can increase metabolism of contraceptives containing only progesterone. As monotherapy, it is started at 25 mg per day for 2 weeks, followed by 50 mg per day for 2 weeks, then 100 mg per day. The dose can then be increased as needed by 100 mg every 2 weeks. Maintenance doses are 200 to 500 mg per day, given in 2 divided doses. Titration rate is half as fast when given with valproic acid, but can be twice as fast in the presence of an enzyme inducer and without valproic acid. Slow titration avoids development of skin rash. An extended release formulation is also available, which allows once daily dosing. Therapeutic level ranges from 2 to 20 mg per liter. Moderate to severe hepatic impairment requires decrease in dose by 25 to 50%. With creatinine clearance less than 10, dose is 100 mg per day. Patients on hemodialysis require supplemental doses of 100 mg after each dialysis. Common side effects include skin rash, which can occur in up to 10% of patients. This is more common in children with co-administration of valproate, fast titration and higher doses. The risk of skin rash is also higher in patients who have history of rash with carbamazepine or phenytoin. Other common side effects include blurred vision, diplopia, dizziness, ataxia, tremor, headache, nausea and vomiting. Anxiety and insomnia may occur. Frequency of sedation and cognitive side effects is much less than with traditional AEDs. Lamotrigine can block cardiac rectifier potassium ion current and can increase the risk of cardiac arrhythmia and sudden death. In combination with other sodium channel blockers, side effects are more common. However, its combination with valproate can be synergistic with greater efficacy than expected. Serious skin rash, including Stevens-Johnson syndrome and toxic epidermal necrolysis, can occur within 8 weeks of initiating treatment, or if medication is suddenly stopped and then resumed at the normal dose. Incidence in adults is 1 in 1,000. Risk is higher in pediatric patients under 12 and in patients taking valproate, ranging from 1 in 100 to 1 in 300. Rash may occur as part of a hypersensitivity syndrome with systemic symptoms including fever, lymphadenopathy, facial edema, abnormal CBC and liver function tests. As monotherapy, it is associated with one of the lowest rates of teratogenicity, which favors its use in women of childbearing age. Drug metabolism is altered in pregnancy and levels may decrease by 30 to 60% due to increased glucuronidation. Increase in the dose may be needed to maintain serum levels, and levels should be checked regularly, at least once per trimester.